Your seat, we'll get started. We cannot stop at just sustaining the Affordable Care Act. We got more to do. All right. There we go.
Thank you, Peter.
Yes,
Well,
my pleasure.
thank you, Peter. We'll ask everyone to sort of get in the seat. We may seem like we're a little bit behind schedule, but we're actually not. We're going to end at 5:30 and transition to the reception. We did originally have 4 speakers who are going to be presenting at our panel. Unfortunately, Sandra Shui has a short-term illness from which she will recover quickly, but was too ill to join us today. So I do send her sincere regrets. But that means we have a little, as much time for our 3 other fabulous panelists. I'm Linda Rosenstock. I'm the Dean of the school that is so proud to be able to host the UCLA Center for Health Policy Research, along with our colleagues in the School of Public Affairs. So in some sense, late in the day, I'm offering a UCLA official welcome. What we're going to do now is, as has happened before, I'm going to introduce each of the 3 speakers on our panel, and we'll still have time left for questions. Our next speaker is known to many of you because of the many different hats she has worn. Senator Sheila Kuehl. She's currently the principal of Kuehl Consulting. She probably has always been the principal of Kuehl Consulting, I think. She has a number of clients, a few that I thought were interesting for you to share with you. Santa Monica College, the City of West Hollywood, and here at UCLA, the Williams Institute. As I think many of you know, she served for 8 years in the state Senate, including being chair of the Senate Committee on Health, 6 years in the State Assembly, and in 2008, unfortunately, because of term limits, had to leave the legislature, but her work and impact continue enormously. In addition, Senator Kuehl has just been a phenomenal champion of the work the center does, a great friend to Rick and his colleagues at the center, to CHIS, and I think to all of us, a great champion for health. So welcome.
Thank you very much. I'm going to speak from here. I'll turn this mic on. Thank you. Yeah. I can't be seen behind a podium. I've been shrinking for 10 years. Lily Tomlin has nothing on me. I have been asked to speak for about 10 minutes about what this year was, before it failed in the Senate, SB 810, which most people refer to as single payer. Others refer to as Medicare for all in California, but anything that gives you sort of the idea about what it's about. And I know you have a watch and I don't. Will you tell me when 9 minutes has gone by? Just, oh, thank you. There was a movement for single payer nationally and in California, actually before the turn of this last century, and even a ballot proposition to establish a single payer system. So if you imagine Medicare, you know what a single payer system is. That is, everyone pays in to a sort of a giant insurance plan, and out of that giant insurance plan, they pay your medical expenses. Really kind of not a new invention. After 2000, a group of advocates who were a little nonplussed that the initiative had not passed and that they felt maybe the people of California didn't really quite understand how this would be so wonderful for them, decided that they might want to run a bill in the legislature. And generally, my staff was so good that people would be coming to our staff and asking us, please, to carry a bill, but not these advocates. These advocates decided they would interview legislators to see if any of them were good enough to carry this bill. And I'm so pleased that I was the winner. It's one of those, was that a good thing? I'm not sure. So one of the first things that we did was to try to figure out how would such a bill be framed. Because it is a very large undertaking to try to establish kind of from scratch a new way of insuring all the people in the state, who then were about 35 or 36 million, and now even more. So one of the first things that we did was to see if we couldn't have a study funded by someone who was not us to ask the Lewin Group, who we found was somewhat trusted on these issues, to look at exactly what it might take to establish such a system. Not to set it up, because those costs would be separate, but to run it. How much would people really have to pay? And what model should we use? And the first decision that we made, for better or for worse, was that since people were somewhat used to a model where employers paid into a healthcare plan voluntarily, some do and some don't, and individuals paid into a healthcare plan to secure their own insurance if their employer didn't, or with their employer, we would ask them to look at a model like that, where individuals who were employees would pay into the plan and their employers would pay into the plan. How much would that end up costing each person, expressed as a percentage? And they did the math based on all of the money that was being spent in that current year on healthcare by insurance companies, by individuals, and even including out-of-pocket, and looked at what it would take to fund it. And what they showed at the time in their study was that generally individuals who were working would pay about 3% of their gross, and that employers would pay about 7% of their payroll. And if they did, that the program, once set up, would be adequately funded to cover the benefits that we wanted to establish for coverage. And they were very generous benefits. They included dental, they included vision, they included everything that you generally call medical care, hospitalization, etc. It was a very complete and comprehensive plan, and the reason that it was so affordable was because the administrative overhead would be limited to no more than 5%, which is higher, actually, than Medicare pays overall in their administrative overhead, and far lower than you find being expended by private insurance companies, who also include what they pay to their shareholders, marketing, etc. So once we had that study in hand, we established a bill and put it up, and it was my intention, because I knew the bill would never pass, it would take a 2/3 vote since it would be expressed as a tax. It would never get a 2/3 vote. So I thought if I could just keep it going all the years that I was there, we could actually develop quite a comprehensive and supportable, defensible bill. So that's what we did. The first year, it was, I think it was called 921, and then in 2005, I brought it back again. We got it through both houses, but all the time you have to understand it's developing in each committee, it's gaining support, it's gaining information, it's gaining a lot of questions, which we attempted to answer and really just develop the program. In 2005, I got it through the Senate. In 2006, I got it through the Assembly. We put it on Governor Schwarzenegger's desk, and he vetoed it. I brought it back in January of 2007. Again, got it through the Senate, further, always developing the concept further. It was called SB 840 in both of those avatars. And then 2008, got it through the Assembly. A lot of co-authors. By the end of 2008's session, we had the support of every labor organization in the state. We had the support of many, well, naturally all of the patient advocacy groups, including, the nurses. But we had some very interesting support from school districts and colleges who had seen over the course of those years what the savings would be like to them, not to mention the state of California itself, in what they were paying for health insurance for their employees. And as you know, there's been a diminution in the contributions to health insurance by all of these entities, and an increase in the contribution to health insurance by individual workers. So you can see that this would have been quite a boon. Put it on the governor's desk again, it was vetoed, and I was termed out. The governor was not pleased with me that year, because that was the year that the comprehensive health bill that Secretary Belshé, then Secretary Belshé, referred to, which everyone thought I killed, but they gave me way too much credit. Instead, I had an 11-hour hearing about the bill, and my members, as they heard about it, decided they didn't want to vote for it, and I didn't even know till the end because they had all told me they were going to vote for it. So in any event, that's why we have nothing, essentially. But now we have the federal plan. And Secretary Belcher and others are serving, as you heard in the last panel, to develop the rolling out of the ACA. This year, Senator Leno was not successful in getting SB 810 through the Senate. I don't exactly know why. Perhaps he seemed too serious about the bill. My approach was always, hey, it's going nowhere. Give me a vote. And, you know, let me keep developing this, because I think at some point, even if it's just our plan that then augments the ACA, because we will be allowed as a state to have a different kind of plan in the future if we adopt it, I wanted a plan that was, as I said, eminently defensible, with every question answered. I still believe very, very deeply in SB 840 or SB 810 or single payer or Medicare for all in California. I honestly believe if it were achievable, it would solve so many problems for all of the people of California. People who are undocumented would have been allowed to pay into it, would not necessarily have been free, but we would have had, of course, to figure out a way that they could declare their income and not be punished, or their employers either. So there were a number of issues, but I think this will be the plan for California once we build the support, educate the electorate, and I still hold out a lot of hope for it. Thank you very much.
We'll give the minute back here in a moment. Terrific. What we'll do is I'll introduce each of the next two speakers as he speaks, and then we'll open it up for questions for everyone. Next, we have Professor Steve Wallace. He's chair of our Department of Community Health Sciences, associate director of the center, and well-known expert in a number of issues, including elder and immigrant health.
Thank you. So I'm going to follow the precedent and just remain seated. It's the end of the day, and hopefully I'll save my energy for speaking instead of standing. So I'm going to, the topic was extending healthcare reform, ACA and beyond, and what I want to talk about a little bit is the best kept secret of ACA, which is the CLASS Act, Community Living Assistance Services and Supports. It's a mouthful. When all of the politics was going on over the passage of ACA, there was a lot of debate over individual mandate, employer mandates, the exchanges, all of these details, and you rarely ever, except if you were a gerontologist, heard anything about long-term care. And at that time, Senator Kennedy had been pushing the CLASS Act for a number of years, and it got into the ACA in both the House and the Senate. It even had some Republican support. And everybody sort of assumed that everything was fine, that it was going to be launched. It was sort of the grandchild of the 1990 Pepper Report, so this has been an issue that's been around for a while. It embodied some elements from the 1993 Clinton healthcare reform attempts, and really looked like time had come. It promised assistance with long-term care services, really with an orientation to home care, which is where most people want to receive their long-term care. It was a cash benefit, which is easy to administer. It's flexible for recipients. It's the kind of benefit that people like. It was voluntary, although learning from the lessons of 403Bs and other retirement systems, it was an opt-out versus opt-in. Now we're getting wonky. So it meant that everybody would be signed up who was at work, and you could say that you didn't want it. And what we find is that people tend to be lazy, sort of like the, going out and shopping for your health insurance on Saturday. Well, you also don't want to go out on a Saturday and disenroll from your health insurance. So the idea was that it would be voluntary, but most people would actually be covered by it. It was premium supported with subsidies for low-wage workers. It was a social benefit. Everybody was included, no underwriting, and so on and so forth. so it seemed like a beautiful expansion, a beautiful way of dealing with the crisis of long-term care. But when it was written, it actually ended up, the legislation was too specific. And so it required, at the last minute, there was a line put in requiring that it show a 75-year actuarial balance. So does Social Security show a 75-year actuarial balance? Does Medicare show a 75-year actuarial balance? Does the any federal program show a 75-year actuarial balance? So as the actuaries sat down and tried to figure out, could they actually show that in 75 years this would be in balance, they could not come up with a scenario to show it. So basically the administration abandoned, suspended, put aside, it's still on the books, but it's not being implemented. So what does that leave us in terms of looking forward? Well, the need for something for long-term care is real. How many people here are baby boomers? Oh my gosh. So this is the demographics that we have to look forward to. We're turning 65. The leading edge of the baby boom is turning 65. And over the next 20 years, as baby boomers all become 65 and over, the number of older adults in California will double, go from 4.3 to about 8.8 million older adults in California. And nationally, the same demographic is happening. And once we reach age 65, what most people don't realize is that 70% of us will need help at home for personal care because of disabilities at some point over the rest of our lives. 70%. So most people, baby boomers are well known for being optimistic and we can do anything we want to and we're never going to get old. But the reality is that most of us at some point will need help at home. Yet at the same time, we also have sort of this Peter Pan fallacy that we'll never get old, and so only about 10% of us have long-term care insurance. Not a whole lot more can afford long-term care insurance, private long-term care insurance, but the actual rates of private long-term care insurance are relatively low. So the need is real, it's not going away, it's going to get bigger, and the UCLA Center for Health Policy Research conducted a poll the last 2 summers with the Scan Healthcare Foundation on long-term care issues around California, and found that last year after the ACA was passed and there was discussion in policy circles about the Class Act, only 5% of California voters age 40 and over had even heard of the Class Act, had any idea what it was. Now, if you ask the same thing about what's an exchange, what's an employer mandate, you might have gotten low numbers too, but that was, I would say, rock bottom. But when described, 80 to 90% of people, when the general outline of what the Class Act offered, when that was described, 80 to 90% said, yeah, that's a good idea. So there is concern. Oops, I don't have it here. Something like 80% of respondents, here we go, 60 to 70% of respondents worried about being able to afford long-term care services when they got older. This is before we went into any details, just at the very front, sort of a list of what types of issues are you concerned about. But they didn't know about it. And only about a third knew what the risks were of needing long-term care assistance when they get old. So the demography is that an increasing number of people will need long-term care assistance. The reality is that most people don't know that they'll need it. They don't think about it. They haven't prepared for it. And they don't know anything about healthcare financing. So I won't ask this group because I'll assume there's a lot of people in here who are knowledgeable about what Medicare covers. But 70 to 80% of respondents did not realize that Medicare does not cover long-term chronic care assistance in either a nursing home or at home. They just sort of assume, and this includes older adults, that Medicare covers all of the health care that you need. They don't realize that it does not cover chronic care. Then we got down to brass tacks and actually told them how much it costs if you're paying out of pocket for a nursing home or for home care. And 2 out of 5 could not even afford 1 month of nursing home care. About half could not afford more than 2 or 3 months of home care. And we told them this after they said that they were worried about home care. So if we asked the question again, I suspect the number worried about paying for long-term care would have shot up. And so sort of the bottom line on this is that the need is there, but the awareness isn't there. And I guess the take-home message is that ignorance is not bliss, because simply ignoring this one will not make it go away. So what about the future? What do we do? What's the post-ACA situation? Well, one is that in the next Congress, I think Anthony Wright mentioned that the next election is an important one in terms of the implementation of healthcare reform, and there are actually some relatively easy legislative fixes that could make the Class Act actuarially feasible. And there's been a number of experts that have looked at that, and they're not a totally new program, they're tweaks, but they're tweaks that have to be made through legislative action, which won't happen in the current Congress, might happen in the next Congress. The other possibility is California could undertake its own program. Senator Kuehl mentioned single payer as an option for acute care services, and there's nothing to stop California from doing its own class-like act, and there is some interest in the legislature in doing a feasibility study around that. So at the same time that we're talking about looking at innovative ways of providing acute care coverage in California, we might be able to do something on long-term care coverage as well. Or, of course, the third option is doing nothing, and we can continue to muddle on and leave people with Medicaid to wait until they're impoverished and desperate and in severe need before kicking in. And I don't think that's an option that most people would like. So let me end on a happier note. It's the end of the day. You've got to have something encouraging. So the ACA did eliminate copayments and deductibles for lots of clinical preventive services. And we heard earlier about the importance of non-medical services or non-medical determinants of health, including tobacco and exercise and nutrition. Another big public health initiative that got a kick with the ACA is increasing the rates of use of preventive care services. So that's the mammography, the colon cancer screening, the tobacco counseling that might help you avoid tobacco use. Currently, though, the population age 65 and over, only about half of them are up to date on all the recommended clinical preventive services. So there's a large area where we can make progress. The Healthy People 2020 goal is to increase that by 10%, and I think with the Affordable Care Act, that will be achievable. That assumes, however, that the only barriers are financial, because those are the barriers that the ACA predominantly addresses. And so in moving forward, CDC actually has taken a major leadership role in trying to think about how we can move prevention into the community. So take it out of simply being in the hospital and the clinic and providing community-based services, whether it's engagement of individuals so that they want to engage in community-based services, community preventive services on their Saturdays while they're off work, or actually providing clinical preventive services, whether it's immunizations or screenings, actually out in community sites. And then the important follow-up, because screening, of course, is designed to catch illnesses early, and so once you've caught them, you need to prevent them. So I think what's important with the ACA that maybe got a little bit overlooked was the importance of prevention in the ACA, and how that really will help move our healthcare system and public health forward in providing clinical preventive services and prevention in general to the population. So that's the positive note. Just to conclude in talking about the mission, the vision that we have, I like a quote from Hubert Humphrey, who was senator from Minnesota, vice president, and a presidential candidate. And he said, "The moral test of government is how that government treats those who are in the dawn of life, our children, those who are in the twilight of life, the elderly, and those who are in the shadows of life, the sick, the needy, and the handicapped." And I think that it's important as we try to move the provisions and implement the ACA that we keep those groups in the forefront. Thank you.
Gosh, how the narrative has changed about what the things we should be worried about. Jerry Kaminsky is our last panelist this afternoon. I know he's been mentioned a few times before, and for those of you, and I hope all of you who join us in the reception will hear more about him later. But for now, let me just introduce him as the center director, the new center director, a professor of health services, and someone I've had the pleasure of working very closely with in his 7 years as associate dean for academic programs, a job he sorely stranded me with. But thank you, John.
Well, thank you very much. It's my pleasure to be, I think, the final speaker here. This is a very distinguished group we had here today, and it really, I think, is not only a great opportunity to honor Rick as our outgoing director and founder of the center, but also to bring together the resources that we have here in California. We have a group of people who have, even our national speakers today, have strong affiliations with California and UC system, and it's been an honor for me over the last 23 years to be part of the University of California system. So I want to address my comments today to some of what I consider to be some of the gaps in the Affordable Care Act and some issues that I think could potentially threaten this program later in this decade. I think we've already heard that the ACA is the most significant piece of health legislation since the enactment of Medicare in 1965. And we've heard today some of the challenges in implementing this program. It still amazes me that, as a student of the Medicare program, and I'm looking at Mark Peterson and Tom Rice, who also have studied the Medicare program in depth and have published a great deal on Medicare over the years, that in 1965, this bill was enacted within 6 months. It was signed by the president at the end of July in 1965. 1 year later, there were 28 million Americans receiving care under Medicare. Today, we are facing ongoing challenges 2 years after the passage of the bill. And as Kim has testified and has spoken in a number of other settings, not just today, the Exchange Board continues to face a number of challenges over the next 18 months to get the fundamental mechanism of healthcare reform up and running so that 4 to 5 million Californians can begin receiving subsidies and signing up for healthcare under the Affordable Care Act. But one of my greatest concerns, and it's been since the beginning, since the passage of the bill, is the threat of rising healthcare costs. And it's not so much because of the increased demand among people who are going to be newly insured, but because of my concern that the mechanisms for bending the cost curve that are part of the bill might not be as effective as people have expected and have sort of sold their merits. I believe that effective cost controls are really essential for the long-term success of the bill, because without such controls, public support for the taxpayer-based subsidies that are so essential to the bill are going to become an easy political target for conservatives who already want to dismantle Medicare by converting it into a voucher program. So I have really serious concern that the vouchers are going to become a political target later in this decade. So what are the mechanisms for bending the cost curve under the ACA that are most likely to be effective? One is the minimum medical loss ratios, the MLRs, for insurers. We've heard a little bit about that earlier today. The ACA requires that insurers, with the exclusion of self-insured employers, comply with minimum MLR ratios of 80% in the small group and individual market and 85% in the large group market. Beginning in June of this year, insurers are going to be required to report 2011 data concerning their MLRs to each state in which they do business. And in August of this year, insurers that don't meet these MLR standards for their 2011 policies are going to be required to rebate differences to their enrollees. So this is a major provision of the bill. It's something that hasn't gotten a lot of press. My guess is that later this year, in June and July, we're going to be hearing a lot about this, and there's going to be a lot of uproar about the fact that insurers are having to pay rebates. And hopefully groups like Health Access will be helping to create some positive uproar surrounding this as well, because this is an important consumer protection. the MLR requirements of ACA may not have a long-term effect on controlling premium growth, but I think it should keep premiums from experiencing the wide fluctuations on a year-to-year basis, which we've observed, particularly in California. And I believe that it'll make it more difficult in the future for insurers to drive up premiums in a rapid way. So I think that these are important protections that are part of the bill and that I think are likely to be successful. In addition, the bill includes provisions for rate review and rate regulation. The ACA provides funding to states to establish rate review mechanisms that require insurers to justify their premium increases. California has already received $4.3 million in federal funds to improve its rate review processes, with this money split roughly evenly between the Department of Insurance and the Department of Managed Health Care, because we have this dual oversight and reporting responsibility in the state with regard to health insurance plans. And although rate review is definitely a step in the right direction, I believe that rate regulation is necessary to effectively curtail excessive premium increases in the future. In California, AB 52, which was introduced by Assemblymember Foyer, would grant authority to the insurance commissioner and to the director of the Department of Managed Health Care the authority to deny premium increases that are deemed excessive. In addition, efforts are currently underway, led by Consumer Watchdog, the Santa Monica-based consumer advocacy group, to include a ballot initiative this November to establish health insurance rate regulation, and the difference being that rate regulation is essentially has more authority. It has more teeth, essentially. I've been asked by various groups during the past year if there's any good scientific evidence that rate regulation rather than rate review is more effective in controlling the growth in health spending. And my response has always been that adequate national data for conducting a rigorous evaluation of rate regulation unfortunately doesn't exist. We don't have good national data to definitively say that rate regulation has been effective and more effective than other mechanisms. But my perspective on this is that, more importantly, rate regulation is a basic consumer protection that we can't afford to ignore. Rate regulation is necessary because consumers deserve transparency and accountability from insurance companies especially when they request enormous rate increases in markets such as California, which are dominated by 5 large insurance companies. Finally, the ACA has a provision for something called the Medicare Independent Payment Advisory Commission, and this is going to, conservatives have already had a field day with this, and as the IPAB begins to operate in 2015, this is going to generate a lot more opposition as well. But beginning in fiscal year 2015, if Medicare expenditures are projected to grow too quickly, the IPAB is required under the ACA to make binding recommendations to reduce spending. Those recommendations will be sent to Congress at the beginning of the year, and if Congress doesn't accept them, it has to pass alternatives and alternative reductions of the same size by August. So this is a mechanism that's part of ACA that really provides a binding mechanism for reducing healthcare expenditures under the Medicare program. As we've seen over the past 2 years since the enactment of ACA, almost every aspect of the bill has been subject to attack. The IPAB has the potential, in my opinion, to be one of the most inflammatory aspects of the ACA because it directly addresses cost increases under the Medicare program. But again, as a long-term student of the Medicare program, and for those of you who don't know, I was a former staff member before I came to UCLA 23 years ago for the government agency that's now known as MedPAC. So I spent the first 3 years of my professional career working on Medicare payment policy issues in Washington, D.C. But I can attest to the fact that despite successful efforts to control Medicare expenditures over the last 3 decades, that these efforts often lead to increases in private health care expenditures to compensate for lost Medicare revenue. So my concern is that once we get to 2015 and have an operating IPAB, that their recommendations, no matter how reasonable and evidence-based they are going to provide endless fodder for Fox News and conservative political strategists to decry the intrusion of government into the healthcare market, thus delaying the serious debate that we need to have, and we need to have it sooner rather than later, regarding whether we can afford to allow healthcare spending to continue to grow at 2 to 3 times the rate of GDP growth. So, despite the firestorm of negative publicity that I expect regarding this IPAB, until there's that organization or a similar one is granted the authority to address total healthcare spending, not just Medicare, but total healthcare spending, I'm afraid that effective cost controls will continue to be elusive, and that will settle instead for cost shifting from the Medicare program onto the private sector, which is what we've observed in various times over the last few decades. So in summary, Steve mentioned that he didn't want to be, sort of end on a negative note. And despite my sort of somewhat gloomy forecast about our ability to control healthcare spending, I do think that it's a serious issue, and I am concerned that once we get through all of the implementation challenges over the next few years and the political challenges, and move forward with implementing the fundamental provisions of healthcare reform, I'm concerned that at the end of this decade, once all of that hard work is done, that it could unravel if healthcare spending continues to grow so rapidly, because I think public support for the subsidies that are such an essential component of the ongoing success of the program will be jeopardized if we can't get total spending under control. Thank you very much.
So we appreciate all of these very different approaches to what we do around and beyond. And now we're going to open up. We have about 15 minutes for comments and questions from our audience for any or all of our panelists. So, actually, I may stand just so I don't miss anyone out of the corner of my eye. If we don't, this is the end of the day, and the only thing, food and drink await us. I appreciate that. Thank you, Tom, for getting in the way. Yeah.
Question for Jerry. In terms of the need for a regulatory body to be able to control premium increases, if in 2014, it'll be fairly easy to compare the exchanges, as Ms. Finn said, that we have a standardization. Why did we need the rate control under that situation?
Yeah, I think that's a great question. So just to repeat, in case you didn't hear in the back of the room, Dr. Rice's question is that if the exchange is really working effectively, and you've got a sort of transparency, and you've got standard products on the exchange, and you have competition among insurers, why would rate regulation be necessary? Because we're trained as economists, we believe that the market that should set up the basic conditions for effective price competition. And I'm optimistic that there will be more competition in the market. I'm confident that Kim and her colleagues are going to establish the board in a way that makes it as effective as possible. But what I am concerned about is that we know that there aren't hundreds of sellers of health insurance in the state of California. There's a handful of large insurers. And even with standard products where price comparison and shopping among purchasers in the exchange, I think is going to be greatly facilitated. I still have concern that there's too much concentration of market power. And so the downward pressure on prices that we might see in other markets where there are lots of suppliers and rigorous price competition, that health insurers might, rather than compete on price, compete on other dimensions, including quality. And I still think that the healthcare market, despite our efforts to reform it, is driven by the perception that low cost means low quality.
I think also you all have a lot of choices as to where you buy your gasoline for your car. And you see how well the market has worked for us on that. I mean, I understand competition is, in theory, something that should allow us to be able to choose somebody saying, well, I'll cut my price so that you'll buy my product. But instead, they just look across the street and change, the number. And before you know it, we're paying $4.29 a gallon, and it was $1.25 20 years ago, So I don't think that the competition alone is going to be sufficient. I think that the exchange giving us as much information as they possibly can and doing what they can to provide information and choices of low-cost coverage where there's a sort of a minimum mandated coverage is about the best we can do now. But I agree. I think we do need those controls, and Assemblymember Fuhrer had a very good bill, and I honestly think that if this initiative gets on the ballot, it could pass.
Jack?
This has been an extraordinary afternoon with some real insights into the full range of things that we're going to have to deal with the Affordable Care Act. One of the things that has struck me about the afternoon is in most of the other sessions that I've been in where we've been talking about affordable care, the panelists have almost leapt through the issue of, gee, this is going to expand coverage, to the issue of how the healthcare delivery system, and by implication the insurance system, is going to have to respond. And we have not had a lot of conversation about that today. We've had some issues raised. The panelists from Healthcare for All noted that the way insurers make money is they sell to the healthy, because if you're getting an average premium, which is an average of the sick and the healthy, you make your money on the healthy, so you try to get more of those, and you try to do things to minimize your exposure to cost from the sick. And that's been the way the system has operated. We know that most of the spending comes from the sick. 80% of the spending is from 20% of the people. Half of that are people who just had really bad luck that year, and half of it is chronically ill people who had bad luck that year and next year and the year after. Mm-hmm. So if we're talking about actually changing how much we spend or changing the growth curve, we've got to deal with that 20% that are going to incur 80% of the cost. And I haven't heard anything about how we change the incentive, really change the incentives for the insurers. Community rating is the same incentive. Average payment for the sick and the healthy. I haven't heard anything about how we really change the incentives for the insurance companies to begin taking the problem of encouraging the healthcare system to manage the care of that 20% with the high costs so it's delivered efficiently as well as effectively. I haven't heard anything about the way the healthcare system has to evolve so that it is more effective and more efficient in dealing with that 20% with the high costs. So if we look to the end of the decade and think about where the insurance system is going, where the managed care systems are going, where the delivery system is going, what's your vision of how it evolves, and where are the external pressures on them going to come from to assure that evolution actually delivers high quality, less costly care?
Do you want to choose where we start? So Jack Needleman, Professor of Health Services. You want to start on your left or on your right?
We can start with that, and since it's late in the day, we've got a bunch of the other panelists who have not left the room, who were on that first panel, and they should jump in as well.
Can I call a lifeline? So I'll start. So this is also partly in response to the previous question from Tom, which is that, again, where's the pressure come from? In the exchange, the pressure comes from standardizing products, implementing provisions that don't allow insurers to split risk between the inside the exchange and outside the exchange. So if you offer policies in both markets, then you have to set the premium equal. You can't try to cream skim. We've got 4 tiers of a standard health benefit package. And we have a risk adjustment if, in fact, despite all these mechanisms, it looks like one insurer ends up with a disproportionate number of high-cost, high-risk patients. That doesn't, however, provide the incentives that you're talking about. Those incentives have to come from elsewhere. There are limited, I think, some limited provisions in the bill to do it, but as you know, Jack, a lot of this bill is financing reform and trying to fix what many of us in the room feel has been a historical problem in the market for health insurance for almost 70 or 80 years in the United States, basically since the formation of health insurance and actually the growth of commercial health insurance after World War II, when we stopped community rating and started allowing experience-rated insurance policies. So I don't know where those incentives are going to come from, but they do, you're absolutely right, that there has to be an incentive not only just to sign up, but to actually control the cost of the 20% who account for a substantial portion of healthcare expenditures.
But I had a question about the question. I thought you were talking about those who deliver health care. Is that correct?
Yes.
So I'm just a layperson, not a professor of these issues, and therefore I'll perhaps just tell you what I think. I guess we're talking about what incentive physicians, hospitals, and those that deliver health care might have to treat those whose treatment might be an expensive proposition for them because they would not be adequately reimbursed under all of these systems?
Well, right now, the way we pay is we pay for services and encounters, so we get services and encounters. And a lot of the betting is that we're going to move to some version of capitation again, which consumers were concerned led to skimping.
But I think it's sort of trying to figure out how the roulette wheel is going to end up, really. And I don't know that any of the assumptions are correct, because right now what we have really is healthcare rationing by insurance companies. They'll tell you what you can do. They'll tell you how much you can do. I heard $70 million was spent last year in California by doctors trying to collect from insurance companies what they said, was due them, and more was spent on the, other side. So if the incentives are for efficiency, then that's one thing. But I know there are others who want to speak on this.
Okay, so I'm going to, we have someone patiently waiting at the mic, but I'm going to, because I've been gestured to, I'm going to ask Rick and Andy to make some brief comments so we can let the last 2 people who have been standing end up with the questions. Rick?
But let me also say one thing about Rick, because that was on my agenda, and of course I didn't. But no, about you, Rick Brown. Not that Rick.
Not Rick Kroenig.
I want to add my praise before the end of this, because I knew Rick kind of from way back. And every time we had a question that had to be answered about our bill, and I think virtually everyone else that brought a bill to the Health Committee, the answer was, well, call Rick Brown. I'm sure they've got some data, that can answer this. And it's been an extraordinary service and an extraordinary center. And a treasure, really, in California and in the UC system, but for the whole state. So I just wanted to add my thanks to you, Rick, with everyone else that's spoken today.
Okay. I think we need you at a mic, if you don't mind, just to... It's changed since you've gone to DC.
I guess so. A lot of the incentive issues that you ask about are, I don't know where he went, are more dealt with on the Medicare side and to some extent on Medicaid than on the exchange. I mean, Jerry did a good job of talking about some of what the exchange will hopefully create in terms of greater transparency and competition. But in Medicare, we've created an accountable care organization programs, both two flavors of them, and have had lots of interest from large medical groups around the country in trying to do this. Well, remains to be seen where that will get, but it's a big change of incentives for physicians and hospitals, investments in primary care medical homes that we're making again through Medicare, work going on also around trying to increase primary care, which isn't directly to your incentive question, but relates to it. And then finally, I would say one of the best kept secrets in Washington is that the projected rate of growth in Medicare spending per beneficiary over the next decade, in the projections that are done by the Congressional Budget Office and by the Office of the Actuary at CMS, are at the rate of growth of the economy. That is basically GDP plus 0. And this is unprecedented in Medicare's history, and they are only projections. And these are actually projections assuming that the sustainable growth rate gets fixed. That is, that physicians do not get hit with a 30% pay cut on February 28th, but that Congress protects that. And assuming that the SGR gets fixed, both CBO and OACT are projecting GDP plus 0 for Medicare spending per beneficiary, and that's actually got nothing to do, or virtually nothing to do, with the IPAB that Jerry talked about. Those projections are a result of the reductions in the Medicare Advantage payments that are in the Affordable Care Act, the multi-factor productivity adjustment that will reduce the update factors for hospitals and nursing homes and other providers. And I acknowledge these are only projections, but in response to your question, Jack, about where are the incentives, well, that creates incentives to spend less money, not necessarily to provide better care, be more efficient, do more for chronic care, but certainly to spend less money. That's going to be a powerful incentive for some sort of change.
All right, thank you, Andy. And then I'm going to go back to the two very patient women who've been at the microphones first and second. But Andy, in a minute.
Well, I mean, I'll just say quickly. I mean, first, thank you, Jack, for your question. I think it's right on. The issue is, we don't have necessarily things off the shelf that we instantly know the solution to. We have a bunch of kind of good ideas about how to change the delivery system, but if there was so much consensus and clarity about that, probably we would have seen more of that in the Affordable Care Act. I think something that I was actually going to comment on, Jerry, when you were saying where are the levers, I thought it was interesting you didn't bring up something like CMMI, which I think is in fact the incubator. The Innovation Center at CMS is really where these ideas will continue to percolate up from. And I think hopefully we're going to make wise investments in ideas. I mean, I think it's astounding to see thousands of applications coming through for some of the opportunities there, and hopefully the best ideas will rise to the top, and that we will learn better methods for how to take homegrown ideas and to scale them up. I mean, I think that's also been a real challenge in our delivery system. We see a lot of good onesie and twosie ideas and haven't really figured out yet all the scaling up concepts. So translational research and from public health schools and from medical schools and so forth and other places needs to kind of move forward. So I think you're exactly right that just kind of fixing the competition at the level of the insurer is kind of just one part, but it's maybe easier to cheat than to do it the right way. Hopefully we'll see good ideas and the incentives changed as people are talking about. I think there's actually a hunger and an appetite in the delivery system to do it better. And believe me, it is incredibly frustrating as a provider to feel like you're doing things that are unnecessary and not the right way to do things, to feel that you're just practicing defensive medicine or because other people do it. And so I think there will in fact be a great embracing of this if in fact incentives can get aligned in a way that will make the providers feel part of the solution. So I think you're right on, and I do believe that the ACA, at least through CMMI, has given a place for this activity to begin. So I see that as another important lever in the process.
Good point.
Okay.
All right. Thank you, and
Thank you, Andy.
time to get to the airport. Yes.
Yeah.
All right. We have please come up to the microphone. Thank you again for your patience. I don't blame you for sitting down. It took a while. Yet we have 2 last comments and questions. Second one here.
Yes, my name is Geneviève Claverol, and actually I write for Working Nurse magazine, and my last article was coming out in the next couple of weeks was on a medical home, and actually the veteran hospitals have utilized them quite effectively and actually show tremendous result in saving of money. And I think you should look at that model. And that model has been used quite effectively for a very long time. And I think, it needs to be looked at. And actually was used in California for a very, very long time. And initially was used in San Diego on asthmatic children for many, many years. So that's a model which should be looked at.
Thank you. All righty.
And I hate to be the last question before you and the reception, so I'll try to be brief. Steve, I appreciated your comments and those of Bob Kaplan's in the previous panel on public health and prevention, part of ACA. And I think that's often left out of these conversations, in part because even though the ACA did, I think, a great job in elevating those issues and investing in those issues, they're still kind of separate. And you have public health over here and the prevention activities over here, and then you have all of the medical system redesign and financing redesign over here. And I'm just wondering if there's some thought about what opportunities the ACA presents to kind of bring them back together in a way that could really enhance the preventive aspects where there could be some real cost savings by reducing the incidence of chronic disease. So just thoughts about through the exchange or through medical system redesign or financing incentives where more than just the clinical prevention aspects, but the more broad public health interventions.
Well, the problem with doing prevention is that the costs of doing prevention results in savings to a different body than those who spend the costs. So even under ACA, so there's increased emphasis on, there's a national prevention strategy now. So ACA has sort of lifted the rhetoric or the discussion around prevention to a higher level, and there are efforts across federal agencies now to incorporate more prevention, but that won't, any spending that goes on there won't come back to help fund that prevention. If you save money in Medicare, it stays in Medicare. If you save money in a private health plan, it stays in a private health plan. And so that's always the conundrum of trying to figure out how to fund prevention, is to try to, just as in acute care setting, is to align the incentives so that the savings from the prevention actually comes back to the people who are spending it. So I don't think the ACA has changed that at all.
No, I don't think, other than the fact that preventive services are, that there are no co-payments, so as an incentive to make sure that individuals don't face financial barriers in getting preventive services. But Steve makes a good point that the savings associated with using those services accrue basically later and perhaps to another insurer, and I think that's one of the reasons why we continue to underinvest in adequate prevention and in not only the use of preventive services, but also in increasing healthy lifestyles. So we heard discussion in the previous panel about all of the determinants of health, and Bob Kaplan's talk was focusing on the fact that the medical system provides a certain percentage. The estimates vary. It might be 50%. It might be as little as 10 or 20% in terms of contributing to our overall health status. So that means we need to make investments in other areas outside the healthcare system to make sure that we're maintaining healthy lifestyles. And that's, I think, been the public health message for as long as the field has been around, for well over 100 years.
As a non-professional in these areas, unlike all the other people in this room, I have to say that one of the very interesting things that I've seen, I like to call myself a Martian anthropologist, is that first of all, silo is the name of the game. Everyone is always in their own silo. They're always concerned about their own silo. They want to talk about working together. They want to talk about how things are connected, but it's very, very difficult to get people out of it, because people are always afraid, is my silo going to lose something, to your silo? So when they set class apart, because long-term care, of course, that's different from real health care somehow, although at my age I'm not sure what that is, then it was easy to carve it away, and there are other things that will be easy to carve away. The other thing I've seen as a public policy enactor is that there's a lot of faith in theories about behavior modification and how you identify a problem, you identify a desired outcome. Public policy is the bridge between the problem and the desired outcome. But all of it is theory. All of it is theory. Are we going to be able to incentivize, which isn't even an English word, healthy living by, okay, fill in the blank. I mean, really, what is it? We tried experiments at school where we paid students for doing physical exercise. That was a good incentive, because money is a really good incentive. But it's only a good incentive if you give it to me to do what I'm doing. And that is not how we use incentives in this thing. If you don't have to pay a copay, we think that you will then go for services more often than if you do have to pay a copay. That's a theory. I'm sure someone's done a study on whether that is the truth or not, but I don't know how many or how perfect. You see, we're simply trying to move the ball down the track, really, on all of this. So thinking about how much faith we're expending in the ACA, not to mention the politics of what could get through at the time, because what fell off, the table as this all went along. So remembering that all of this is really just a theory about behavior modification and guessing whether people will or will not respond.
So let me close with two words on that, or two directions, health policy directions. One is health impact assessment. So this is an area that's been growing. We do environmental impact assessments whenever we have any new policy, any new bills. It says what's the impact on the environment. It can be environment neutral, but actually cause poor health outcomes because it makes communities less walkable, it makes the air worse, et cetera, et cetera. So to the extent that the National Academy of Sciences came out with a new report led by a member of the School of Public Health, Dick Jackson, that actually talked about the importance of health impact assessment in all the policies that we have in our country and moving forward, so that when we build new communities, we think about walkable communities. When we talk about agriculture subsidies, we think about how that impacts the availability of fresh food and healthy food. When we, et cetera, et cetera. So health impact assessment is one. And then the last one is in public health, we talk about the social determinants of health, and that was a little bit earlier. And the new jargon in Washington, to make it more palatable and understandable, is health in all policies. And from people I've talked to in DC, that actually is bringing together transportation and labor and health and human services and EPA and all of the different departments that actually do have an impact on our health, and bring them together at a cabinet level and talk to each other about how do we think about the health impact of our policies. So health impact assessment and health in all policies, and I think
and there are
that
no
will get at
silos
some
in
of the
Washington,
prevention.
D.C., so I'm sure that's going to work extremely well. So anyway, thank you very much. Terrific afternoon symposium. I know that, speaking of incentives, that we're hoping all of you will have an opportunity to join everyone on the patio for informal discussion as well as a few more remarks. Am I able now, Rick and Jerry, to close the session? Or
Just, nope,
That's
wrap it up.
Okay, let's get up and move. Fabulous.
Move 'em out.